Please join me to welcome our first speaker for today, Dr. Margaret Zervos. Dr. Zervos is the Emeritus Infectious Diseases Division Head at Henry Ford Hospital in Michigan. He is an expert in antimicrobial resistant, antimicrobial stewardship, and global health initiatives. Dr. Zervos will be discussing an important component of antimicrobial resistance, the challenges faced outside of high resources settings. His presentation titled Global Antimicrobial Resistance and Antimicrobial Stewardship in Research Limiting Setting. And without further ado, the floor is yours, Mark.
Okay, sorry, sorry for the delay. It's so antimicrobial resistance has gained a lot of attention both in the medical community, but also among the general public worldwide. It is one of the leading uh, causes of infection-related mortality worldwide, along with HIV, malaria, tuberculosis, and diarrheal diseases. In addition to it being increasingly recognized as a serious threat to public health, it's been recognized by almost every public health and professional organization in the world about the need to address it. Probably the most important um, global uh, action that occurred was related to a United Nations General Assembly meeting that occurred in 2016. It was only the fourth time in the history of the UN that that any health topic was addressed at a General Assembly, and antimicrobial resistance was also recently addressed at a General Assembly meeting just last year again. To show the issue with antibiotics, we had the discovery of penicillin in 1928, its first use in the 1940s. And then a number of different agents were found and were developed and through the 1970s, 80s. But after that, there have been relatively limited new agents, resulting in the further need for us to preserve our existing agents. What is the threat? The threat is often difficult to explain because we use complex names and abbreviations: CRE, MRSA, MDR, VRE, NDM, and others. We talk about resistance in terms of percent resistant isolates, but patients and policymakers don't care about percent of isolates. What they do care about is the impact on numbers of infections, morbidity, economic cost, and mortality, which is very hard to measure. What we do know is that resistance is everywhere, and also that countries have varying rates of resistance, which is proportionately greater and more serious in low and middle income country settings. These are some of the threats, and the most important threats have been in multi-drug resistant gram-negative bacteria, but we still see issues with MRSA and VRE and drug-resistant strep pneumo. Most recently, we've had issues with Candida auris, and then in low-income country settings, issue with drug-resistant salmonella and Shigella. This slide shows resistance rates globally, and to the top left is third generation cephalosporin resistance in Kleb pneumo, showing that much of this resistance is in South Asia and also in Africa. To the right of that is carbapenem resistant Acinetobacter, similarly in South Asia, but also in parts of Latin America, Argentina. And to the bottom left are third generation cephalosporin resistant E. coli, which are also a problem in Southeast Asia, not as much of a problem in the western part of the world or in Africa. For Staph aureus has historically been more of an issue in North America, Latin America, but now we see methicillin-resistant Staph aureus occurring worldwide, but not as much of an issue as is multi-drug resistant gram-negatives. The consequence of antibiotic resistance is that we have an increase in antibiotic use that results in further increases in resistant strains, ineffective empiric therapy, increased hospitalization, increased use of healthcare resources, and then further limiting the treatment alternatives. Antibiotic resistance has been considered to be a silent pandemic, and looking at just the year 2019 alone, an important publication in Lancet described over 4.9 million deaths that were associated with antimicrobial resistance worldwide, 1.27 million deaths that are directly attributable to AMR. And resistance to beta-lactam antibiotics, fluoroquinolones, accounted for most of these deaths. And in these reports, only stroke, ischemic heart disease accounted for more deaths that year. So when you put antibiotic resistance together with cancer or heart disease, then it becomes more than a silent pandemic. It's just a huge, enormous worldwide issue. Age-related deaths were highest in low middle income countries. Overall, AMR in this report was the third leading cause of death, and this slide shows the death rates by country or by region. And sub-Saharan Africa, Asia had the highest death rates in the 204 countries that were looked at. The standardized mortality rate that was associated with AMR was 75 per 100,000 population. In terms of the economic impact, antimicrobial resistance results in more admissions, longer hospital stay, longer and expensive treatment, and again, LMICs are disproportionately affected. So to the top left shows the percent of the GDP and costs that are related to AMR. So the red are is the amount of GDP impact, showing that it reaches up to $300 billion, and then in the for low on the high income countries. So for low income countries, they are disproportionately affected in that they have a higher percentage of their GDP is associated with antimicrobial resistance, not as much in terms of billions of US dollars that are spent. Cost of hospitalization also varies by country. So if it is a low income country, cost of hospitalization about 1,200 US dollars, but for a high income country towards the bottom right is about $40,000 for a hospitalization for a resistant bacteria. This study was a study that was done by the World Bank in 2024. They also looked at cost versus benefit, showing that that by better treatment, that there was that the benefit was at least 28 times the cost. In looking at antibiotic resistance, we look at it using a One Health approach. The One Health approach dates back to the 1800s, and what the concept is that there should be no dividing line between the environment, humans, and animal health. It's endorsed by now just about everybody: CDC, WHO, UN, ministries of health, and others. And part of the reason for this is that about 75% of newly emerging infectious disease and 60% of all known human infections originate in animals, which is the importance of looking at not only humans, but also environment and animals. This is a One Health approach or issue is definitely the case with looking at antimicrobial resistance. because when we use antibiotics in humans, that of course results in resistant bacteria that can spread between people, but the use of antibiotics in food animals results in not only contamination of the food, but also of the environment that can make its way into people in a bidirectional manner. There have been estimates that up to 50% of all of the antibiotics that are used in food animals, and there are many classes of antimicrobial agents that are used in food animals that are also used in humans. There are a number of factors that contribute to antibiotic resistance, and having sick immunocompromised patients is, of course, one reason in hospitals, in the community, especially in low-income settings. Having poor sanitation is also an important risk factor for acquisition of resistant organisms in the community. But the biggest driver of antimicrobial resistance is misuse or use of antibiotics, either in humans and or in animals, as is shown in this slide. There's considerable variability in antibiotic use by country. This slide shows antibiotic consumption in DDDs per 1,000 inhabitants per day by country. And you can see that the countries to the left of the slide, Cyprus, Greece, Romania, Bulgaria, have highest rates of antibiotic consumption, both of the WHO access and watch reserve classifications, and others then towards the right have relatively lower rates of antibiotic consumption. Netherlands has consistently been very favorable in how they've done with antibiotic use and antibiotic consumptions, and have been a model in many ways for the rest of the world. This is as just mentioned, the WHO access and watch group, reserve group of antibiotics. This is used especially in lower income countries to design national action plans and antibiotic use guidelines. The access group are agents that can be used generally without any restriction. The watch group require more careful, more restricted use, and the reserve antibiotic use like daptomycin, aztreonam, and so on should be used. Fifth generation cephalosporin should be used ideally with some restriction of use globally. So in assessing the global challenge of antibiotic resistance, we know that it's not going to be easy. We know that it will require aggressive action in every region, and it also requires coordination between countries. We need to evaluate and eliminate gaps, and the call for global action has occurred by WHO, UN, national action plans in many countries, and also many other initiatives. In assessing the global threat, the United Nations enumerated in its General Assembly meeting what are the components that should be utilized for control of antibiotic resistance globally, with focus on low middle income countries. And one of the starting points is that each country should have a plan for antimicrobial resistance reduction, and it should be done in a One Health context. And now, many countries do have, in low income countries, do have national action plans. The overall plan components should be to build laboratory capacity. Being able to do surveillance is always a first step, and that includes being able to do basic microbiology, antibiograms. There are some countries that they're so low income that they're not even able to do basic microbiology. Improve surveillance, and there's several global surveillance systems, GLASS from WHO, where countries submit information to the WHO that's summarized and then periodically published. It was just a report from WHO that was a summary of the GLASS findings, but the results of antibiotic resistance by country can be found on the GLASS WHO website. We need new tests and diagnostics. We need inexpensive tests that can be used in middle income country setting. We need new drugs. We need antibiotic stewardship, both inpatient and outpatient, in formal and the informal sector. Reduce of antibiotics in food animals, elimination of growth promoting antibiotics. There have been good studies to show that growth promoting antibiotics are not needed, that if there's appropriate hygiene or sanitation on the farms, the addition of growth promoting antibiotics doesn't add anything. We need better infection prevention and infection control in hospitals, and prevention strategies such as immunization by giving, there have been studies that have shown that by giving strep pneumo conjugate vaccine, that results in penicillin resistance. Hopefully, as a result of doing things like giving conjugate typhoid vaccine, that will also result in reduction of resistance in Salmonella typhimurium. We need innovation and including alternatives to antibiotics. So in thinking about antibiotic stewardship and LMIC, we need to contextualize it. We need to contextualize by country. LMMC have diagnostic challenges. There's a high burden of infectious disease. There's often very limited laboratory capacity. There needs to be an increase in knowledge and an awareness. Healthcare workers prescribing antibiotics will have different backgrounds, lack of information on antibiotic use. Guidelines are often limited by lack of locally applicable high-level evidence. In many situations, there are not personnel that are specifically trained in antibiotic stewardship pharmacists, as an example, in infectious disease. Physicians don't exist in many low-income country settings. There needs to be better access to quality assured antibiotics. Many countries have very poorly regulated or limited access to essential antibiotics. There's a lot of non-prescribed use, a lot of over-the-counter use. You can go into pharmacies in many countries and get just about anything. And there are financial incentives for these outpatient pharmacies to provide antibiotics on an outpatient basis. And also, importantly, to impact resistance, are that healthcare facilities often have limited infrastructure. They have limited equipment, availability of interdisciplinary personnel. So the WHO has a action plan for reducing antibiotic resistance globally. This is in the process of being updated. The updated version is not yet available. But the first pillar is improve awareness and understanding of AMR through education and risk communication. Secondly, strengthen knowledge through surveillance and research. There should be a improvement of laboratory capacities and surveillance done both at a local level, but also at a national and global level. To reduce, number 3 is reduce incidence of infection, and that's infection control, WASH, healthcare associated infections, community level protection, things like sanitation, and then look at animal health, both prevention and control. So and then number 4 is optimize the use of antimicrobials, and that includes access to agents, but also regulation, and also includes use in veterinary and and agriculture settings. And then the fifth strategic objective is to ensure sustainable investment in countering antibiotic resistance. So it's measuring the burden, assessing investment needs, and establish procedures for participation in the process. We know that if we're going to deal with antimicrobial resistance globally, it's a global disease, it needs global solutions. The roadmap is to build partnerships, and it includes the role of governmental entities, various international agencies, and also the role of and also the academic community has an important role. The tools include national and international initiatives. WHO has set out a roadmap and also has provided tools, and there are local regional examples and initiatives at the both facility and community level that have been successful. For hospitals and for resistance in general, One Health approach, and it's important to recognize that both the community and the hospital is interrelated. What we're seeing in low-income country settings is that people are coming in to the hospital with antibiotic-resistant bacteria. So it is, I mean, they're coming into the hospital when they have community-acquired pneumonia with organisms like Klebsiella that are ESBL producers, or they're coming in with other infections due to resistant gram-negatives or Acinetobacter. You know, even if resistant Acinetobacter, even if they've never been in the hospital before, recognizing the relationship of the community to the hospital is important. It's important to recognize that antimicrobial stewardship is part of infection control in hospitals. We need to operationalize partnerships between the hospitals, academia, public health, and government, develop twinning relationships, bring together various groups and collaborative complementary efforts. There are a lot of people that are doing work in the field, but often in low-income country settings, the work isn't coordinated. There are people that are doing duplicate efforts or efforts that aren't coordinated in any way. And finally, use implementation science to evaluate what is being done and to evaluate outcomes. There are many tools that are available for reducing antibiotic resistance, antibiotic stewardship in low-income settings. These are some examples. WHO has various policy guidance that have been that are available. We were involved. Our hospital was involved in working with WHO to develop a toolkit for antimicrobial stewardship in low and middle income country settings, and it has several components to it. It has structures for national programs, structures for and recommendations for healthcare facilities, how to plan an AMS program in a health facility, how to perform interventions, how to assess the program and the interventions, how to do education and training. We developed this toolkit together with WHO. It was piloted then in Nepal, Bhutan, Micronesia, and Malawi. It is a feasibility study, and now it was implemented after that across the globe. There's a newer version now of this toolkit and a policy guidance by WHO that's also been recently developed. It also includes a system for measuring for doing the needs assessment of each of the facilities. So what are the interventions? The interventions in the low-income country setting are going to be similar to what we're doing in hospitals in the higher income settings, country settings, but it'll include education guidelines, um, pre-prescription, post-prescription reviews, timeouts, stop orders, de-escalation of redundant therapy, IV to oral conversions, optimized dosing, audit and feedback. Use of EMR is not as going to be as is used as much because many low-income countries don't have an EMR in their hospitals. Allergy evaluation, and then regulatory control. There aren't usually for most low-income country settings there isn't a restriction process where somebody has to get a prior approval for an antibiotic to use it. Although some countries and some hospitals do have that. It's important to remember the principles of antibiotic use. More is often not better. So we use initial therapy as broad, especially in a sicker patient, but then de-escalate, start antibiotics promptly, get cultures, but only get cultures if the patient has an infection, not if they're colonized. Don't over culture. Don't get cultures, for example, on a wound that's not infected, or get a culture on a urine in somebody who has a indwelling bladder catheter and doesn't have evidence of a UTI. Know when to say no, and stop treatment when cured. Shorter is better. This is one of the most important ways to reduce unneeded antibiotics in low-income country setting. It is because often, because the lab is limited, they're not able to get cultures and de-escalate, based on the culture. What they are able to do is to cut the antibiotics short, or not give it too long, in based on their guidelines. So for community acquired pneumonia, instead of going 10 to 14 days, just go 5 days, would be one example. Consider for pharmacodynamics, adverse effects, outcomes, and also consider the cost of use. One of the most important measures for control of unneeded antibiotics are guidelines. And guidelines are based on international recommendations. WHO has guidelines for use. Now, many countries in their national action plans have recommendations for use of antibiotics for specific infections. That should be based on the local antibiotic resistance patterns, their antibiogram, what agents are available, which agents are cost effective, and they can use local, national, international standards as tools, but it needs to be adapted to their own hospital or own country setting. Need to develop these guidelines with consensus, make them available at the point of care, keep them simple, and prioritize, and then monitor their use as process improvement and as an education tool. I've seen guidelines. I just reviewed a guideline it was a beautiful guideline. I won't say which country, but it was like 170 pages. So it was beautifully done, very comprehensive. But something simple that the clinicians can use at the bedside is important in things like what are the antibiotic recommendations, how long to treat for one infection or another is most useful. So a guideline should have empiric antibiotic selections. What are the definitive antibiotic selections if an organism is isolated? Recommendations for IV to oral conversion, dosing, and especially important is duration of therapy. These are some examples of guidelines that we developed in Nepal and then in Micronesia, and then we had meetings to educate the staff on the use of the guideline. Guidelines were consensus, and because there are no infectious disease physicians, there's no there are no infectious disease pharmacists. What we did is to train the staff to do post prescription audit and feedback using the guidelines, and that was a successful way to reduce unneeded antibiotics. Part of the work that we've done, and I'll give a few examples to show what can be done, because there are a lot of initiatives that are being done to reduce unneeded antibiotics and control resistance in low income country settings. Part of our work, I give Nepal as an example, has included workforce training of physicians, nurses, midwives, and pharmacists, various implementation initiatives, and studies of enablers, barriers, attitudes, and dispensing practices of antimicrobials. These are some of our meetings, and again here at some of our meetings. But I'll give some examples, and these are from 3 hospitals: Kathmandu model, Pokhara is a large government facility, and these are all in Nepal, and then Kirtipur Hospital is a burn unit. And what we did in each of these institutions was to work with them. We used we used WHO and national guidelines, but we adapted those guidelines to their hospital with a consensus of the institution, developed a local hospital guidelines for antibiotic use. Then we did the training of staff, and then what was done was post-prescription audit and feedback. So what would be done would be that somebody would go and review an order for antibiotics at 48, 72 hours, and if it didn't meet guideline, there would be guidelines, and there would be an intervention that would be done where there would be a discussion with the staff, and it was shown to be an effective way to reduce unneeded antibiotics. This is another example. And this is in India, at CMC, which is in Vellore, India. This is a 2,300 bed hospital. It has over 8,000 outpatient visits a day, so very large, busy facility. And we did the same thing. We worked with the CMC to develop guidelines for use, and then they did post prescription review, audit, and feedback, and they were able to reduce carbapenem use almost 9%. They reduced colistin use 9%, and they reduced days of antibiotics overall 9.5% in their study. What they've done since then is that CMC has been a leader in India in doing this, is to train pharmacists to do antibiotic stewardship in hospitals there, because there are a few infectious disease physicians in the country, but there are many more pharmacists, and the training of the pharmacists has now been increasingly recognized as an important tool to reduce unneeded antibiotics in low income country settings. In Latin America, we were involved in multiple AMR projects, but the most important is a project called PROA, and that's initially involved 9 Latin American countries, 77 ICUs, and work with them to look at to develop guidelines, and then to look at their adherence to guidelines. And when the guidelines were adhered to, the countries where the guidelines, hospitals where the guidelines were adhered to, there was reduction in crude mortality, and reduction in antibiotic use, and even some improvement in drug-resistant bacteria over time. This project is now continuing, and has had also some support from the U.S. CDC and others to be able to continue. In the MENA region, and I just returned from a trip to Jordan. We have a number of projects, including looking at MDRO in refugees or as a result of conflict, post-prescription review and feedback projects are also being done. Twinning relationships, diagnostic stewardship is being done in hospital-based programs, and there's there's no ID fellowship program in Jordan, and we co-created an ID fellowship program with one of the universities and hospitals in Jordan to train ID physicians. So in the evaluation of programs, evaluation of AMS programs, it is important to provide targets for the indicators, and these are going to vary according to the local setting, but at the minimum, there should be some measure of antibiotic use as a result of it happens as a result of the intervention. There should be a possible evaluation of process structural measures and quality measures, but the I would say the most important would be the measure of antibiotic use, and then ideally patient outcomes. So what are mortality, readmission, length of stay, MDRO, multi-drug resistant organism rates. One of the mechanisms for control of AMR, and I mentioned before that that to deal with AMR it requires partnerships. It requires partnerships between the ministries of health, the hospitals, the universities, the public health entities. It is these collaborations have been can include the academic community. This is our Wayne State University Center for Emerging Infectious Diseases, and our theme is training, education, building community research and public health, and as a result of this center has been involved in various local initiatives, including initiatives in the city of Detroit, but has also been key in building on some of our work and relationships in the countries that we're working in globally. So what I'll finish with is a reminder that the global crisis on antibiotic resistance is getting major international attention, and efforts are starting to happen and to follow. But the hard part is that how do we get the resources to solve the problem? How can we be most effective in addressing the problem? How do we get people that are working in the field to be coordinated in activities? What are the priorities? What does each country do to address resistance? So countries have great national action plans, but how do they implement those plans? What can each of us do? How can we learn to work better together? There are many examples at the facility level, community level that can be models for work in low middle income country settings, and ideally establishing mechanisms to continue those initiatives and to build on them is critical. What is the role of WHO and other public health entities to continue to set out a roadmap to combat AMR, and to continue to provide tools for addressing resistance. What I'll finish with is the point that to remember that also finish with is that we share common problems. These problems are controllable, and it is the responsibility of the global community. Initiatives should be developed to overcome economic, social, religious, governmental, regional barriers for prevention and control. This requires a long-term commitment, new sustainable solutions, partnerships, and multidisciplinary support. And all of us can get involved. There are many opportunities for building on this work. We do have the power to prevent and defeat infectious diseases, but we need to step up the fight. As Fauci noted, the battle is a continual process. Winning does not mean stamping out quote is that winning does not mean stamping out every disease, but rather getting ahead of the next one. And Joshua Lederberg noted that we must pool our greatest resources, our imagination and intellect, pitted against the microbes. We mainly have our wits. And with that, I'll stop. I'm 2 minutes early, but I thank everybody for your time and your attention. Thank you very much.
Thank you so much, Mark, for a wonderful presentation. You definitely are doing a lot of amazing work and very meaningful work, because we all understand that when it comes to AMR, there's no boundary, right? Because it's gonna go everywhere, especially for the low and middle income countries. So now for our attendees, please use the chat or raise hand functions to ask questions to our speaker. But I see there is one question in the chat, so I'm going to kickstart. So this is from Kelly Kongsberg. So the question is, was there one international outreach that was especially meaningful to you personally? And if so, what makes it stand out?
One international. No, that's a really important question. One international outreach. I think um, there are a lot of challenges now. It is we had we have had the support for doing international work has been cut back by the by U.S. government, so that has created a lot of challenge. The I think the one effort that has been the most important has been an effort in training. And the thing that I've actually been most encouraged with has been the training that's been done of pharmacists. It is we've seen because pharmacists in many low income country settings, the pharmacists are dispensing or they're dispensing drugs, but the but each hospital has pharmacists, and with an increasing recognition of the importance of antibiotic stewardship, many hospitals now have agreed to for the pharmacist to participate or lead antimicrobial stewardship. So I would say what's been the most important intervention has been training of pharmacists in antibiotic stewardship for the hospitals.
Thank you so much, Mark, for your answer. And I have actually follow-up questions, actually, too, you don't mind. So, so you have focused a lot on global health and antimicrobial resistance. So, in your experience and your expertise, what do you think is the role of the non-governmental organizations in bridging the gap between the national health policy, the on the ground for like the sustainable stewardship practices?
Yeah, no, thank you. That's an important question. Well, I think the academic community has a very important role. The academic community can participate in twinning relationships, in conducting research, in providing technical guidance. It is so for example, we our institution, our Center for Emerging Infectious Disease, our institution is an academic entity, does do twinning relationships and provides technical guidance and also provides training. But we're not there. We're not in the country. So I think what is most useful for an academic center is to or community is to develop a long-term, not to go in and out of a country and do a study and then come back out again, but to develop long-term relationship with the country that includes training and technical guidance for a country and that is sustainable. So I would say that for a non-governmental agency, the academic community would be to develop twinning relationships for training, research, and um, technical guidance. There is some other than governmental agencies. There are various NGOs that get involved in doing global health work. There are foundations that also get involved, and foundations have been an important mechanism to fund some of the projects. So there's always a need for funding, and especially now that U.S. government has cut back on some international aid, having uh, foundations provide support has also been important.
Yeah, I definitely agree with you, Mark, because like I think the one thing that we all can agree upon is across all different core elements when it comes to antimicrobial stewardship, education is the common core element across all different settings. So definitely, like I think that is one point that we can do for a resource-rich nation or even resource-rich like academic center to really share the knowledge and help educate because we can only do so much for one person, but we have to got give them the knowledge for them to able to do it by themselves and able to sustain the interventions. All right. Is there any other questions from our attendees for today or Dr. Zervos? All right. So we're hearing none. So please join me to give Dr. Zervos a round of applause for his wonderful presentations. Thank you so much again, Dr. Zervos, for taking your time and participate and support such important initiative, especially for our low-income countries.
Thank
And
you.
with,
No, thank you very much.
yeah, no, absolutely. And then if anyone had any other questions, we have Dr. Zervos' email on the screen.